Okay, we're going to get started. So again, welcome everyone. My name is Megan Jackson. I'm a physical therapist. We are here today to talk about benign paroxysmal positional vertigo, also known as BPPV. Learning objectives for today. The first one is to demonstrate an appropriate understanding of the anatomy and physiology of the peripheral vestibular system, including otolith organs, semicircular canals, vestibular nerve, and the vestibulo-ocular reflex. Second, we're going to understand the pathophysiology and clinical presentation for BPPV. And then third, analyze the results of positional testing for BPPV and choose evidence-based interventions. A little bit about me. So again, my name's Megan. I am coming to you from Chicago. I wish it looked that blue skies, but today it's rather gloomy and rainy. A little bit about me. I'm a physical therapist. I've been practicing for about 12 years. I have clinical experience in a variety of settings: acute care, inpatient rehab, and outpatient. I am a board certified neuroclinical specialist. I lecture for the University of Illinois at Chicago for their physical therapy program, for their vestibular unit, and I'm a proud alumni of UIC as well. I have some experience in healthcare management as well as clinical education. This topic is important to me for many reasons, but I have personally experienced vertigo and have had BPPV, so I understand how it feels. And then a little bit more about me, just for fun. I enjoy exercising, watching Chicago sports. Right now I'm really into the Bulls, traveling, and recently took up golf. During the pandemic, it was a new sport I picked up. If you play golf, I'm sorry. Frustrating game, but it can be fun. So we are going to start off with a poll here, and we'll be coming back to this type of poll throughout the lesson to check learning. So we're trying to spot the lie. So the game is two truths and a lie. On your screen, you can choose which one you believe is the lie. And then I'll look at the poll results and see what everyone thinks. So the options are that nearly 40% of US adults experience vertigo at least once in their lifetime. Individuals with vestibular disorders have 12-fold increase of fall rates. And then rehab interventions do not improve outcomes for people suffering with BPPV. So go ahead and make your choice here, and then I will reveal to you which one the lie is. Okay, I think we have a clear winner here. Let's look at the results. All right, so 83% of you all believe that the lie, once again, we're looking for the lie, so the false statement is that rehab interventions do not improve outcomes for people suffering with BPPV. So let's go ahead and look. And of course, you are all correct. And that's why we're here today, is to find out what we could do for people suffering with BPPV. We can help them. So that's the good news. All right, let's get into it, starting with anatomy and physiology of the vestibular system. I'm going to move through some of these slides fast because I want to make sure we get to the assessment and treatment part of BPPV, but it is important for us to understand what is going wrong so we can help ourselves identify appropriately when it is BPPV versus not. So first of all, this slide is adapted from Herdman's text from 1994, talking about how we maintain our balance. So the sensory input is going to come from three places: visual, vestibular, or proprioceptive input. We are going to focus only on the vestibular portion of sensory input. And then it will be processed by the central nervous system, and the output is going to be something motor. So either eye movement or postural movement to keep ourselves in balance, right? So again, we're going to talk only about vestibular system today and move kind of quickly through this. So first of all, let's talk about the peripheral vestibular system. And this is located in the inner ear. So there is what's called the bony labyrinth, and that is, think of like negative space within the skull bone. So that is, in that picture, the blue space, and that's in the temporal bone. It's filled with something called perilymph fluid, which is very similar to CSF. Now, within the bony labyrinth exists something called the membranous labyrinth. and that is a delicate structure. Within that structure is endolymphatic fluid, and that's highlighted because we're going to come back to endolymphatic fluid again when we talk about BPPV. More about the peripheral system. So it's comprised of our sensory organs, which are semicircular canals and otolith organs, and then the vestibular portion of cranial nerve 8. We're going to focus first on the semicircular canals. So these are responsible for sensing head rotation and angular acceleration. So head rotation, meaning turning your head left to right, up and down. It needs to be rotating around a pivot, versus linear acceleration would be your head moving as if you're in a car, like straight forward or back, or up and down like you're in an elevator. So semicircular canals are just sensing this angular acceleration of head rotation. Now there are 3 semicircular canals in each ear, and they are named for how they are aligned to the horizon. So the first one is the horizontal canal, and that one's the easiest one to imagine. It is oriented 20 degrees superior from the horizon. Off of that canal, the posterior and anterior are aligned all 90 degrees perpendicular to each other. And this is important because it allows our head to detect angular acceleration in all planes of movement. So if we look at a different view, so this picture is looking from the top down through the head. And I want to point out that we know there's semicircular canals now in both ears, but the way that they are arranged is so that they are opposite one another, and there's always an opposite canal being stimulated or inhibited. So for example, the left anterior canal, which is that blue arrow pointing forward, is opposite the right posterior canal, okay? So when this left anterior canal is stimulated, the right posterior canal is inhibited. Same thing for the other canals. So the right anterior canal in green, when that one is stimulated, the left posterior canal is inhibited. Same thing with the horizontal, left and right. And this is called the push-pull mechanism. And it's important because it helps us understand head movement within space. Okay, a little bit more about the semicircular canals. So at the end of every canal, there is a receptor of angular acceleration. This is where the ampulla is located. So if we're looking at that picture again, the semicircular canals each have an ampulla at the end of the canal. The other side of the canal is open for the endolymphatic fluid to flow back into the vestibule, okay? Within the ampulla, there is a mass called the cupula, and that's highlighted again in pink. If we look down at that smaller, like blown up version where the arrows are, the cupula is this gelatinous material that bridges the width of the ampulla. So endolymphatic fluid cannot get past it on the end of the ampulla. It can only go out the other side of the semicircular canal. And again, the cupula is this gelatinous material. Let's look a little bit closer at that. So in this, I don't know if I mentioned, but the cupula has the same density as endolymphatic fluid. Therefore, it is not gravity dependent. So think of it kind of like with bubble tea, if you know what that is. There's these little orbs that are floating in liquid, and they have the same density, so they don't like float up or down. They just kind of stay where they're at. Same thing with the cupula. Now, when the head is moved and the endolymphatic fluid flows, that's going to bend the cupula. So that is in that second picture there. Because of head movement, the endolymph flows and bends the cupula. All right, let's look at it another way. I just kind of flipped the picture on its side so we can think about it again. So in the top picture, because even though gravity is straight down on it, the cupula is still straight across the ampulla because, again, it's the same density as the endolymphatic fluid. The only way it moves is if there's head movement or head rotation, causing the endolymph to flow and then pushing that cupula. So within the cupula, there's something called nerve cell or hair cells. And these are like the nerve endings of the vestibular nerve. So when the cupula is deflected, it's going to bend these hair cells, causing either depolarization or hyperpolarization of that nerve. So if we look over to the right again, in figure B, I think that's the best one to look at. The hair cells are straight up and down. They're not being deflected. That means the head is not undergoing angular acceleration. And that vestibular nerve has a constant firing rate of about 90 beats per second. Okay. Now, in the second picture, the hair cells bend towards the kinocilium, and this part's not important, but that will depolarize a nerve, increasing the firing rate. If it bends the other way, hyperpolarize, decreases firing rate. So take-home message is when the head rotates, the cupula is deflected, the hair cell bends, it changes the firing rate in the vestibular nerve. Putting it all together. So this is an example of a head turn and looking at the left horizontal canal nerve firing rate. That's what we're looking at. So with your head stationary, so that center picture, right, that nerve is firing at 90 beats per second. Head is stationary, cupula is not moving. Now with a left head turn, the cupula deflects and the vestibular nerve increasing the firing rate. If the head turns the opposite direction to the right, that left horizontal canal will decrease firing rate of the vestibular nerve. All right. So we got through semicircular canals. We're going to talk briefly about otolith organs. So these are going to detect that linear acceleration, so horizontal or vertical. Now, the important part I want to point out in relative to BPPV is that the utricle, which is one of these receptors, is located right outside the opening to the semicircular canal. So in that upper right-hand picture where I put the arrows, that's where the utricle is located, right outside the semicircular canals. The utricle has another gelatinous material called the macula, but the difference with this is on top of it are these carbonate crystals, or calcium carbonate crystals called otoconia. And that's going to be an important thing to remember. See, they're sitting on top of that jello, kind of embedded in it. Those calcium carbonate crystals have a different density of, like, they're have more weight than the endolymphatic fluid. When those become dislodged from the utricle, that's when it's a problem, and it turns into what we know as BPPV, which we'll get into shortly. Okay, back to this organization of the postural control network. We are skipping over central processing for today, and we're going to talk about these motor outputs, which is the one that we're talking about today is the VOR, and that controls eye movement. So the VOR is responsible for maintaining stable vision during head movement. So whenever I think about a reflex, think about the words of the reflex, and that will help you understand the input and the output. So the first word is always the input. So the input to the reflex is going to be the vestibular system being stimulated, which we know now is by head movement. So that's the input to the reflex. There's quick connections in the central nervous system. The output is going to be ocular movement. Okay? So with a head turn, our eyes are going to move equal and opposite direction relative to the head turn, and that is a normal reflex. The VOR is highly adaptable, so that's why therapy can be effective when we have an impaired VOR. A normal VOR, the gain is 1-to-1, so the velocity of head movement is equal and opposite the velocity of the eye movement. So let's look at an example of VOR in action. So you might recognize this little girl from a meme. She's giving us a side eye, but imagine she is looking at a stationary target and moving her head. If you see me in the video, I can demonstrate that. If you look at your thumb and then turn your head to one direction, your eyes are going to stay on your thumb and they're moving equal and opposite my head movement, right? That's the VOR at work. So in this picture, she has moved her head to the left, and we're just going to say it was 20 degrees. Her eyes are going to move equal and opposite her head to the right. And that is a result of the cranial nerve 8 or the vestibular nerve changing firing rate, right? That is a VOR, a summary of the VOR. Now putting it all together. So this is a busy slide, but I want you to kind of think about what's happening so we understand normal physiology for when we talk about the pathophysiology in a moment. Okay. I think it's good just to focus on the excitation side of this, which is the pink. So in this schematic, they're showing the right semicircular canal. It is being excited. So that means we did a right head turn. During a right head turn, the endolymphatic fluid flows, right? Bends the cupula, bends the hair cell, causes the nerve to be excited. Through rapid connections in our central nervous system, the output is going to be to our ocular motor neurons, okay? So a right head turn is going to cause excitation of the medial rectus of the right eye and the lateral rectus of the left eye, causing our eyes to move opposite head movement, okay? Now this is a reminder, remember every semicircular canal has an opposite canal where the endolymph is flowing in the other direction. So on the left side, the exact opposite's happening. The endolymph's going in the other direction, causing the cupula to deflect in the opposite direction, and then causing inhibition of those motor neurons. Almost done with the vestibulo-ocular reflex. So this is just kind of to review, but with your head at rest, so this top picture, the firing rate of both vestibular nerves is 90-90 at rest. With the left head turn, there's excitation of the left vestibular nerve and inhibition of the right. So the brain is going to interpret this difference in left and right as a head turn, and that will stimulate the VOR. All right, I know that was quick. In our longer classes, we can go a little bit more into detail, but I think that was a good overview. So let's check our understanding with two truths and a lie. So we are looking for the lie, and I'm going to help us out with this because this is a lot of words. So let's kind of read it together and then think through which one we think is the lie. And if you want to go ahead and vote right away, that is fine too. All right, so the first one is during a left head turn, the firing rate of the left vestibular nerve increases, which is stimulated, yes, and the firing rate of the right vestibular nerve decreases. So left head turn stimulates the left vestibular nerve. I think that's true. All right, let's look at the next one. While the endolymph in the right anterior canal flows towards the kinocilium, endolymph in the left posterior canal is flowing away at equal speed. So remember, that's the push-pull mechanism. So the right anterior canal is opposite of the left posterior canal. So if one's flowing towards, the other one should flow away. So I think that's true. Let's read the third one. During a single head turn, the endolymph through the semicircular canals, the endolymph flows through the semicircular canals while the head is undergoing angular acceleration. When the head stops moving and is stationary, the endolymph continues to flow, taking time to slow down and stop. All right, great. About half of us have answered. Let's go ahead and look at the results. Okay, good. 96% think the last one's the lie. Very good. All right, so let's think about why this is the lie. And I was trying to trick you with this. So let's go to the next slide. That's number 3 is the lie. So during head movement, that is when the endolymph is flowing. Once your head stops moving, the endolymph stops moving as well. And that's important because when we get to BPPV, the problem is the endolymph is flowing when your head's stationary. So our brain is going to be confused by that. So again, this is at normal head, like at normal speeds. Think of a little kid like spinning around in a circle for very fast. In those cases, the endolymph, the reason they feel dizzy is the endolymph is still moving after they stopped moving, and they feel dizzy. But during normal head speed, normal movements, the endolymph will stop after you stop moving your head. Okay, let's talk about differential diagnosis and clinical presentation of BPPV. So the first thing to address is nystagmus and understanding what nystagmus is and how to look at it. So this is a rapid involuntary beating of the eyes. It can be physiological, so maybe you were born with nystagmus, or pathological. And today we're going to talk about pathological nystagmus. The direction of the nystagmus is always named as if the patient is sitting in the upright position, and it's named for the fast phase of nystagmus. So, for example, upbeating nystagmus would be towards the patient's forehead. That would be the fast phase. Now, nystagmus is a response of the VOR being stimulated incorrectly, and then a saccadic reset of the eyes. So, for example, if we're thinking about upbeating nystagmus, so again, that is nystagmus where the fast phase is towards the patient's forehead. What is happening? So an impaired VOR is moving the eyes opposite of perceived head movement, slow. So in this example, your brain is perceiving your head is moving in the up position, and so the eyes are moving slowly down opposite the perceived head movement. And then there's a saccadic reset or a fast upbeat to reset the eyes because your head is not moving. It's an impaired VOR. So let's look at an example of nystagmus and try to understand what we're looking at. So this one is an example of upbeating nystagmus. So it's just what we just talked about. So the slow movement is down, the fast movement is up. Let's watch this video here. Okay, so it's going to begin. The nystagmus will start after a brief delay. Here it goes. So as a clinician, pick one part of the eye to look at. I usually choose, if you can see like a blood vessel in the eye, which is hard to see with this one, or a striation in the iris, that's always good, but just pick one spot to look at. And we're trying to see which direction is the fast movement. So in that example, that was upbeating nystagmus. I think it's worth looking at one more time, and we'll have some more practice with looking at nystagmus again later in this lecture. So this is a delay in the nystagmus because this patient has BPPV. And you're going to see that fast phase is up. It's almost like thinking of like the ball is bouncing upwards. Okay. So if this is your first time seeing nystagmus, I would recommend taking a longer course to get more practice with this, but there's also some really good videos on YouTube that you can practice looking at as well. Again, we'll come back to that a little later when looking at some cases. So this is to call out there are many different diagnoses that can cause a patient to feel dizzy. Typically, we put those into three buckets: peripheral issues, central issues, and then other causes of dizziness. Today, we're just going to focus on the diagnosis of BPPV. So what is it? So it stands for benign paroxysmal peripheral vertigo or positional vertigo. It is the most common peripheral vestibular disorder and accounts for over half of the cases. So very commonly in physical therapy, I know we get orders for vestibular PT with a diagnosis of BPPV, even though sometimes it's not. But I think a big reason why, and it's important for us to know, is that over half of peripheral vestibular disorders are BPPV. So chances are it most likely is, but it's important for us to understand how to diagnose it because there is a chance that it's not. It is the second most common cause of episodic dizziness after orthostatic hypotension. Lifetime prevalence of BPPV is 3% and increases with age, its incidence. It's 2 to 3 times more likely in women versus men. I'm not sure why. We do have some data about vitamin D deficiency that we'll talk about a little bit later, so potentially that's why. And then I think this is interesting, a study from 2007, but it was talking about the use of resources for people that have BPPV. So 86% of affected individuals, it has led to medical consultation, interruption of daily activities, or sick leave. And you'll learn shortly that it is relatively easy thing to diagnose and treat. So I do think that we have some work here to do to reduce the impact on these resources. Okay, let's talk about more about what it is. So those otoconia, or the crystal carbonate, calcium carbonate crystals, become dislodged from the utricle. And in most cases, it falls into the posterior canal. So that's about 80 to 90% of cases. If it's not the posterior canal, most likely it's going to be the horizontal canal that's affected. That's between 5 to 15%. Anterior canal may be affected, although rare, but it does happen. The otoconia cause the endolymph not to be gravity dependent. Now, what is the cause? 50% of the time, we don't know. It's idiopathic. There is some evidence to show that head injury or concussion can lead to BPPV. Vitamin D deficiencies, such as with people with osteoporosis. There's a thought also about degeneration of the macula with aging. I'm gonna watch this video kind of to put it, make a little bit more sense of this. So those little dots in the middle, those are the otoconia sitting on the utricle where they're supposed to be. Now, for whatever reason, they become dislodged, and I think that's gonna happen here in a second. The patient now lays down on their back, and those utricle or those otoconia fall into the posterior canal. When they sit up, it's going to take some time for the endolymph to flow while the crystals fall to the bottom. Now, this is a mismatch, right? The head is stationary, but that endolymph is flowing, causing the vestibular nerve to be stimulated. And I kind of think of it like a snow globe, like the amount of time of a snow globe it takes for those otoconia to fall down. The patient's going to feel that dizziness while it takes time for the crystals to fall to the most dependent position in the semicircular canals. So this kind of puts it all together. So with head movement, the otoconia move to the most gravity-dependent position in the canal, causes the endolymph to flow, the hair cells to bend, the vestibular nerve to start change the firing rate, and the VOR is stimulated. The endolymph will continue to move even after the head has stopped moving. So this causes the VOR to be stimulated, causing what? Motor output. And we just learned about it. That is that ocular output. So our eyes are going to move opposite perceived head movement at a 1-to-1 gain. There will be a quick reset to the midline, which is known as nystagmus. And this will continue happening until the endolymph stops moving. So another video I think is helpful. And this one shows the endolymph moving, but then also what happens. So this is normal. They're doing like a head turn side to side, and the endolymph is moving during head turns. Now with the otoconia, the head is not moving, and it's taking time for that otoconia to get down to that most dependent position. And then let's look at what happens with the eyes. So see, the eyes are upbeating and torsional, and that's opposite perceived head movement. That's the symptoms of BPPV. Okay, so what's a patient going to feel? So they're going to have nystagmus. They're going to have a sensation of dizziness and spinning. It will most likely be short duration, 10 to 20 seconds. And think again of that snow globe. Think of the otoconia making their way down. And this type of BPPV is known as canalisthesis. So there are two types. We're going to focus on canalisthesis. That is the most common, and that's the one I just described of those free-floating otoconia within the endolymph. The symptoms are going to be short. There's another one called cupulolisthesis. So if the patient's nystagmus is long-lasting, you might want to consider that that is a diagnosis, although much less common. All right, some things to know, because your patients are going to ask, what's going on with this? What can I expect for the future? So first thing, benign. You want to remind them that it's not due to a serious condition and it has a favorable prognosis. It can spontaneously recover. So at 1 month, about 20% recover, and at 3 months, 50% recover. The treatment for BPPV is canalith repositioning procedures, and that is what we're going to learn today. And that relieves vertigo in 80% of patients after just 2 treatments. So that's what you have to convince them of. I need to treat, this is the treatment, so stick with me. And then recurrence rate, that is always the next question. Will this happen again? At 5 years, the recurrence rate is up to 50%. So you can inform them of that as well, but let them know it's benign. So you know what to do next time this happens. Get in and see me ASAP. All right, another poll here. So let's spot the lie again, all right? So the reason people have vertigo with BPPV is because the otoconia within the semicircular canals make the endolymph gravity dependent, causing the endolymph to flow after the head has stopped moving in relation to gravity. Posterior canal canalicesis is the most common type of BPPV. And then recurrence rate is extremely rare. So which one is the lie here? Great. Okay. Most people have answered. Fantastic. Let's take a look. All right. 96% say that the lie is that BPPV is extremely, or the recurrence is extremely rare. Okay, let's see. So yes, you are correct. That is the lie. Remember, recurrence of BPPV at 5 years is about 50%. So I would not call that extremely rare. You want to warn your patients that they might have it again. Great. Okay, let's talk about management of BPPV. So as far as the vestibular exam goes, this is the order I typically go in, starting with a history and then working through a lot of other differential diagnosis, with positional testing being the last thing. So we are going to skip 2 through 6 and just talk about history and then positional testing. So history. You want to ask them about the dizziness. Describe the dizziness without using the word dizzy. They will most likely tell you about a spinning sensation. Ask them about tempo. Okay, so how long does it last? When did it come on? It's going to come on suddenly, and it lasts typically less than a minute. And is this dizziness associated with anything? You may hear that it's associated with head positional changes relative to gravity. So things like it happened when I turned over in bed, or when I got out of bed, when looking up to the ceiling or looking down to the floor. Those would be common complaints. Although you will hear many other things. It's not that crystal clear, right? Okay, let's look at this CPG. This is a CPG in the American Academy of Otolaryngology and Head and Neck Surgery. It's from 2017. It was updated then. And whenever we have a clinical practice guideline, we're really jazzed about it because it gives us clear guidance as to what to do. So in regards to the diagnosis of BPPV, there's a strong recommendation for the Dix-Hallpike to diagnose posterior canal, a recommendation for the supine roll test to diagnose horizontal canal, and then recommendations against. So we should not be ordering radiographic testing for patients that meet the criteria of BPPV, right? Once you have a positive Dix-Hallpike, there is no need to do any radiographic testing. Same with vestibular testing. And what they're talking about here is vestibular testing with an ENT. We do not need to order that testing if they meet the criteria for BPPV. So let's talk about positional testing. So some things to think about before getting started. We definitely are checking cervical active and passive range of motion, asking about pain, injury, surgeries. We are going to have them in a position of head rotation and extension. So you need to think about any relative contraindications or precautions. I have a few there. I'm sure there's more, but think about the position of the neck and if that's safe for the patient. Preparation. So avoid vestibular suppressants. The most common is called meclizine. Depending on where you work, you can figure out a way to communicate to the patients or to the nurses, providers, to avoid meclizine prior to vestibular or positional testing. Reason being is it's a vestibular suppressant, so you may not get as robust of a response, and it's going to be harder for you to diagnose what's going on. Tell the patient to avoid eating and drinking immediately before the test, as it may bring on their symptoms. You're going to situate the room and the surface by removing bed rails or the head or base boards of a bed. Like if it's a hospital bed, for example, have a stool close and an emesis basin ready just in case. Ideally, we'll be using Frenzel lenses or infrared video goggles, and there's pictures of those there. Now, Frenzel lenses, that's the top picture. Those are the less expensive option. The purpose of both of these is to eliminate visual fixation of the patient. So all they see is basically like blurry gray. They aren't able to fixate their eyes on anything. And then it allows the examiner, us, to see their eyes more clearly. So with Frenzel lenses on that top, you can see that her eyes are magnified and lit, like backlit, so we can see her eyes better. With the video goggles, even better, because you can record the eye movement and then watch it back, which is very helpful. However, most clinics don't have those. If you do, that's really lucky, and it makes it a lot easier. If possible, we want to demonstrate, back to the video and Frenzel lenses. You can do this test without those goggles. I would recommend that when instructing the patient of where to look, have them look at a far distance. So for example, like look towards the ceiling. Don't look at your face, because your face is very close to them and they can almost like visually override the nystagmus. So have them look further away. If possible, demonstrate the entire test or show a video. And you need to tell the patients this is going to bring on your symptoms. But rest assured, BPPV is benign, and the treatment for it actually starts in this testing position. And I can help you with this today. So stick with me. And I really need you to keep your eyes open throughout the entire test. So let's take a look at the test. Other things to note. As the examiner, you're going to note, as you're watching, the latency of the symptoms. So you're going to ask and watch. How long does it take in the testing position before they start to feel dizzy or before you see the nystagmus begin? The latency can be anywhere between 1 second and 40 seconds. So understanding that is important. We need to hold the testing position for longer than 40 seconds if you aren't seeing anything, because it might take up to that amount of time for you to see any symptoms. We're also going to note the duration of the symptoms and then the direction of the nystagmus. Okay, Dix-Hall-Pike, that is going to be our first positional test that you'll start with. The directions for the test are all listed here on this slide. I will show a video of it, which I think will be helpful. But before we get started with the video, let's talk about the purpose. So the Dix-Hall-Pike test is to test the posterior and anterior canals for BPPV. And you can see the picture with the examiner having the patient lay down on their back. I just noted that with their head turned to the right in this picture, you are testing the right posterior canal. And then of course, there's an opposite canal we're always testing, so that would be the left anterior. I think an easy way to remember this is that posterior canal is the most common. You turn your head to the right, you're testing the right posterior canal. Just one little tip. So let's watch a video. And so this one is going to be Dix-Hall-Pike on the left. And before I start it, you see I have a stool behind me, so I'm able to sit down quickly. And then I've already told the patient the directions for the test. All right, so turn the head 45 degrees to the left. You can start with a little extension so they know what to expect. Then you're going to have the patient lay down quickly and extend their head off the table. Hold this position for at least a minute or until the symptoms come and go while noting how long the symptoms are, and then assist the patient back up into sitting. Okay. I'm sure you're already thinking about some of your patients that can't get into that position. We don't have time today, but there's a lot of ways that you can alter this. The biggest thing is that it's all about your head position relative to gravity. It has nothing to do with your neck extension. It's all about your head relative to gravity, right? So let's look at another example. This one is for the right Dix-Hall-Pike. And this way you can, it depends on your preference, what is easier for you and the patient. In this one, I'm standing in front of the patient, and it allows them to kind of hold on to your arm, and they may like that a little bit more. So it just depends on your setup and your patient preference and your body mechanics. Let's take a look at that. So we're going to turn the head 45 degrees to the right. So this is testing the right posterior canal. Ask the patient to hold onto your arm. An instructor, you're going to have them lay down quickly. You're supporting their head. Okay, as quickly as you can. Keep their head off the table, extended, and we're looking at their eyes for nystagmus. At least a minute, or until symptoms are completely gone, and then have them sit back up. When the patient sits up, they most likely will be dizzy again, so it's good to spend a little extra time there guarding them and ensuring that they're going to be okay. Okay. So with the Dix-Halt Pike, let's talk about what we are seeing and what does it mean and how do we diagnose BPPV. So again, lots of words on this test or on this screen. The interpretation of the test is always in the testing position. So that will be the second position down here with the patient's head extended off the table. We are looking at the nystagmus in that position. So if we see upbeating nystagmus in that position, again, that means towards the patient's forehead, that's going to be the posterior canal that's involved, right? And it's going to be the posterior canal that you're testing. So again, in this picture, they're testing the right posterior canal. So if I see upbeating nystagmus in this position, that's going to be the right posterior canal that has the otoconia within that canal. If you see downbeating nystagmus towards the patient's chin, that'll be anterior canal. Again, anterior is much less common. You will see a torsional component with the nystagmus. That's normal. With posterior canal, you will see torsion. With anterior canal, sometimes you do or don't. Now, differentiating canalicesis from cupulocesis depends on how long the symptoms last. So with canalicesis, that's that snow globe. So it will last as long as the otoconia are moving. That's typically 10 to 20 seconds in the testing position. If it lasts more than a minute, then we're thinking it's cupulolisthesis, and that would be a different treatment intervention. Okay, so let's watch some nystagmus again and decide what we're seeing. And we'll talk through it. So the patient's sitting, we had them lay down. There's no nystagmus yet. Now it starts. And it's like a crescendo of nystagmus and then a decrescendo. All right, think to yourself, what direction do you think that nystagmus was in? So that was upbeating nystagmus. Okay, so that's posterior canal. Now here is an evaluation in the emergency department. So this is a left Dix-Halt Pike. We already know it's anterior canal. So this is, like we said, very rare, but it can happen. And here's proof. So this left Dix-Halt Pike, you start seeing downbeating nystagmus. And notice there is no real torsion. Torsion is like almost like spinning of the eyes. It's just purely downbeating. Now, it's important that with the diagnosis of BPPV, we see that the nystagmus eventually will diminish, and it does in this case. So this is anterior canal. That would be the right anterior canal that is impacted. Okay. Great. All right, moving on to the next positional test. So you did the Dix-Halt Pike, you did the left, negative, no symptoms. You did the right, no symptoms, okay? So you've ruled out anterior and posterior canal on both sides. The next test to test for would be for the horizontal canals, and that's called the supine roll test. All right, so this patient is in supine, and you're testing both canals at the same time because of that push-pull mechanism. So let's watch the roll test. So you will take the patient's head into about 20 degrees of flexion, and then as quickly as they can tolerate, turn their head to the side. The test recommends 90 degrees of rotation, but it's going to be whatever is accessible for the patient. hold them in that position for at least a minute, looking for nystagmus, asking about symptoms. Then back to center, give them a break there, and then same thing to the right. Turn to the right, ask about symptoms, watch for nystagmus. If this is positive, you're gonna see nystagmus towards both sides with the roll test, okay? And that's because of the push-pull mechanism. You're testing, when you turn their head to the left, you're testing both canals. When you turn the head to the right, you're also testing both canals, okay? So the way to determine what kind of BPPV is the direction of nystagmus. Once again, interpretation while in the testing position. So the testing position for this picture is number 2 here with where I put the arrow. That's testing to the right. And then testing to the left is number 3 here, okay? So what is happening in those testing positions? If you see geotropic nystagmus, meaning that the eyes are beating towards the floor. So in position 2, their head is faced towards the right, eyes beating towards the floor would be right beating nystagmus. Then you turn their head to the left, you're gonna get towards the floor or geotropic nystagmus, that'd be left beating nystagmus, okay? If you see geotropic nystagmus, that is canalicesis, the diagnosis is gonna be the side that has more robust symptoms. Let's take a look at an example. This is a video of the supine roll test. So in the bottom right corner, it shows the patient is turning their head all the way to the right. The eyes begin beating. That is towards the patient's right. That nystagmus is right beating nystagmus. So it's your left, but the patient's right. It's about to stop now, slowing down. The examiner turns their head a little bit more to the right. We're not going to see much of a difference because that otoconia has already fallen to the most gravity dependent. Now the examiner is going to move their head all the way to the left. That's a normal response to the VOR you just saw. Now the head's stationary towards the left. There's a latency, nothing's happening with the eyes. And there it goes. So that now it's left beating nystagmus. So it's a little less than it was on the right side, but that's towards the patient's left, which would be, they're laying on their left side, so that's geotropic nystagmus. So I am going to diagnose this patient with right horizontal canal canalicesis BPPV, because on the right side, she's back on her right again. She has more robust symptoms when her head is turned towards the right, and it's geotropic nystagmus. That's the testing for BPPV. So some more tips here. So the nystagmus will reverse directions when taking them out of the testing position. So with the Dix-Hallpike, if you have left posterior canalicesis, when they're laying down, you'll have up beating nystagmus, and when you sit up, you're going to have down beating nystagmus. That is normal with BPPV. The roll test we just showed, her nystagmus changed from right to left. That's a normal response. Okay. If you have direction changing nystagmus while the patient is just sitting upright and you didn't do the test, that's very concerning of a central pathology, which could be like a stroke, for example. Okay, back to the CPG for treatment. So strong recommendation for CRP, which is canalith repositioning procedures. We are going to review the treatment for canalicesis today. There is a strong recommendation against post-procedural restrictions. So no longer do patients need to sleep in a lazy boy or wear a soft cervical collar. And another recommendation against the use of meclizine to treat BPPV. Next slide. This was from October 21st of this year, so very recent. It came out. This is a systematic review about the use of vestibular suppressants for BPPV. And this quote is straight from there. So in patients with BPPV, vestibular suppressants may have no effect on symptom resolution at the point of longest follow-up. However, there is evidence towards superiority of CRM or CRP same thing, over these medications. Vestibular suppressants have an uncertain effect on symptom resolution within 24 hours, repeat ED visits, patient satisfaction, quality of life, and adverse events. This data suggests that cannula repositioning maneuvers and not vestibular suppressants should be the primary treatment for BPPV. This is a helpful article. If you're seeing meclizine still being used to treat BPPV, this is new and hopefully a nice resource to bring back to our physician partners. So the treatment for posterior canal canalicesis is going to be the Epley maneuver. On this slide, it demonstrates step-by-step how we're doing it, but we'll go ahead and watch the video. So in this video, we're going to treat right posterior canal canalicesis BPPV. So the lucky thing is it starts in that Dix-Hallpike position. So that right posterior canal, turn the head to the right 45 degrees, have the patient lay down, head extended off the mat, hold it here for the symptoms to go away, and then add an extra 30 seconds just to be sure those otoconia are at the most dependent position. Turn their head to the left, so now they're left 45 degrees while maintaining that extension. Same thing, hold it here, symptoms plus 30 seconds. After that, you're gonna ask the patient to turn onto their side, and you'll turn their head so that their nose is pointing towards the floor. And so I've noticed in this position, sometimes I have to ask the patients to kind of turn a little bit more to get their nose down towards the floor. Can't see their eyes, so you'll have to ask them when their symptoms stop and then add an extra 30 seconds. Once that's done, kick your legs off, sit the patient up, make sure you're guarding here because they may be feeling a little woozy. That is the Epley maneuver for right posterior canal BPPV. What if it's horizontal canal? The treatment is called the barbecue roll. Let's watch this one. So this one starts again with the roll test, kind of similar to what we did with the Dix-Hallpike. So this is treating right horizontal canal. It's going to start with a right head turn, which is that, remember that roll test position. Hold for symptoms plus 30. Head to center. Symptoms plus 30. 30 seconds. Head left, same thing, hold for symptoms plus 30 seconds. At this point, you're going to ask the patient to get into prone on elbows. So they have to be mobile to do that. Hold it with their head kind of facing the floor, but in neutral spine for symptoms plus 30 seconds. And then, depending on how mobile, scoot off the table, stand up and sit down. If they can't scoot off the table like that, you could just keep rolling in the same direction and make it a 360 turn. That is fine as well. If your patient isn't that mobile, another option is called the Gaffani maneuver. And with this one, the patient's sitting edge of mat, and you're going to have them rapidly lay onto the side, the unaffected side for canalicesis. So this is for left horizontal canalicesis. So I'm going to have the patient lay down quickly on their unaffected side, which would be their right. Lay down quickly. And then I'm going to turn her head to face towards the mat. Hold this position for 2 minutes and then assist the patient to sit up. That is called the Gaffani maneuver. So it's for horizontal canal canalicesis. It's also used for cupulocesis, but in a different manner. Okay. All right. That is a treatment for BPPV. Again, high quality, compelling evidence that patients diagnosed with posterior canal and lateral canal BPPV should be offered expeditious treatment of CRP, and that's straight from that clinical practice guideline. Now we're going to repeat the maneuver 2 to 4 times during that session if the patient can tolerate it. Some people talk about considering canal conversion during that, maybe wait 15 minutes between treatment. Personally, I don't have that kind of time, and I haven't seen a large amount of canal conversion by not waiting 15 minutes. So that's just preference, I think. Recommendation to recheck for 24 hours later if you can get the patient in ASAP. Consider antiemetics, so something like Zofran if the patient has severe vomiting. Home exercise program, you can give them the self-epi for posterior canal, but consider the individual patient if they understand very clearly the directions. And once again, no post-procedural restrictions are required. I want to point out Brandt-Daroff exercises. This was initially developed as a treatment for BPPV, but we've learned a lot, and this is not the treatment, but CRP, the Epley maneuver or the barbecue roll, that is the treatment for BPPV, because think about it. We need to move that otoconia out of the canal, right? So with the Brandt-Daroff exercises, it's not specific to any canal and does not do the full rotation of the canal, so it's not going to remove the otoconia. Although it can be used as a habituation exercise for patients that aren't responsive to BPPV treatment, or they have kind of persistent debility from it. That's an option for habituation. All right, 2 truths and a lie. We're gonna spot the lie here. Okay, so MRI is best to diagnose BPPV. Patients with BPPV should not be given gaze stabilization exercises as initial treatment. And symptoms of canalisthesis BPPV are brief, typically 20 seconds. Let's see, where's the lie here? So we know it's initial treatment for BPPV. That is canalith repositioning procedure. So patients should not be given gaze stabilization, so that is true. Symptoms of canalisthesis is brief, 10 to 20 seconds. We know that's to be true. So MRI, that is, I don't think that's it. Let's see what everyone says. Okay, the lie is MRI is best to diagnose BPPV. You all are so smart, you're correct. The best way to diagnose BPPV is through positional testing. MRI won't even show it, so that will be a waste of time and money. All right, another 2 truths and a lie. Brandt-Daroff exercises should not be considered as initial treatment for BPPV. Clinicians should instruct patients to perform smooth pursuit or saccadic eye exercises for patients with BPPV. Clinicians should not routinely treat BPPV with vestibular suppressants such as meclizine. So this is looking at treatment, initial treatment for BPPV. So remember, the best treatment for BPPV is the canalith repositioning procedures, such as the Epley maneuver and the barbecue roll or Gufani. So Brandt-Daroff should not be considered as initial treatment. That's true. And then remember, there is a systematic review that said meclizine is not going to be used to treat BPPV. So I think we've decided where the lie is. This is a tricky one. So the lie is the second one. Okay, so clinicians should, the lie is clinicians should have patients perform smooth pursuit and saccadic exercise for BPPV. So smooth pursuit exercises is following a target with your eyes, with your head stationary. All right, saccadic would be eyes between 2 targets. Okay, neither one of those exercises is doing anything to my semicircular canals or moving that otoconia out. So that is the lie. We should not be giving those. All right, let's jump into a case here. So this is Carol. She was referred to outpatient clinic for eval for falls and dizziness, past medical history of cancer, breast cancer and osteoporosis. Her complaint is a spinning dizziness when getting out of bed. It subsides quickly, but she's been feeling off since it started 3 days ago. What is our suspicion? Sounds like BPPV. The symptoms are brief, associated with positional changes. It sounds spot on for BPPV. So we did a screening with her. Her gait and static balance were normal. Ocular motor test was normal. Head impulse test, which we didn't cover today, but that was negative. So what tests are we going to now do to rule in or out BPPV, and what order? So we're going to do positional testing. The posterior canal is the most common. So we're going to start with the Dix-Hallpike and see if that otoconia is in that posterior canal. If both are negative, we're going to consider horizontal canals and do the supine roll test. Let's watch the Dix-Hallpike for this patient. So this is a left Dix-Hallpike, heads turned to the left. There's a brief latency, and then the nystagmus starts and subsides. So we have to decide what direction that was in. And here it goes in slow motion, which makes it a little easier. Watch that. So the fast phase. So that is upbeating nystagmus. All right, so here it is, left Dix-Hallpike. Had upbeating left torsional nystagmus. What's our diagnosis? Left posterior canalicesis BPPV. What's our treatment? The Epley maneuver. We're gonna repeat it 2 to 4 times this session. Ideally, we'll have a patient come back within 24 hours or as soon as we can get them in. No post-procedural restrictions are required. And then, of course, patient education on BPPV and recurrence. So just a little bit more about Carol. So the risks of BPPV development are a little higher in patients with osteoporosis due to calcium homeostasis. So that's an interesting thing that is more recently understood. So patient education is going to be really key here about recurrence. Fall prevention training, think about fracture risk with this patient. And then some interesting research has been done about with some medications to improve vitamin D levels and that reducing the recurrence of BPPV. So something to consider when talking with providers and patients. All right, let's go to this Q&A and see if we have any questions. The first question is there another BPPV treatment for cupulocesis other than the Gaffani? Yes, there are. We didn't cover cupulocesis today in detail, so it depends on which canal it is in, but there are various liberatory maneuvers that we can use for cupulocesis. All right, next one. In the roll test to help diagnose canal versus cupulo, are the onset of symptoms similar to the Dix-Hallpike, as in a sudden onset, short duration for canalus versus delayed onset, prolonged cupulo? Good question. Yes, typically for the canalicesis, you're going to see that latency, then a crescendo, decrescendo. For cupulocesis, it will last longer. I have not seen that in my career for horizontal canal. I think it's pretty rare, but it would be more sustained, and then you'll have that apogeotropic nystagmus as well. Okay, let's see what else we have. And then why are they no longer recommending post-Epley precautions like laying flat, et cetera? Good question. There's been enough research just to show that it doesn't make a difference, no significant impact. That isn't to say that you can't still do it, because it doesn't cause any harm either. So we've had a lot of conversations about that, that if it's not causing harm, then why not? You can still prescribe it, but it hasn't been shown to make a difference either. So, and that's straight from the CPG from 2017. All right. Well, it looks like those are the questions. Thank you all for joining me during your lunch and learn today. If you are interested in learning more about vestibular rehab and assessment and intervention, I do recommend you check out some of our summit courses. There are much more information for longer classes. We can cover it all. So thanks, everyone. Have a great day.